So hi everyone, welcome to our final event for our General Medicine crash course. This session will be a continuation of our first endocrinology event led by Dr. Aaron Patel, who is currently studying his AFP in endocrinology. As usual, please keep your microphones off and videos off and pop any questions you may have for Dr. Patel in the chat, and I'm sure he'll answer them either throughout the presentation or after. So yeah, without further ado, I'll let Dr. Patel take over.
Perfect. So hi everyone. So this is the second part of the talk that we'll be covering. Just thank you again to the BIMA committee for organising this. So last time we covered thyroid, adrenal and pituitary. So this time we'll be looking at diabetes firstly, then looking at some electrolyte imbalances, and then finally we'll be touching on multiple endocrine neoplasia. Something a bit more niche, but something that you just need to have a brief overview about. So we'll just start with an SBA first of all. So start with, this is a case about a 46-year-old woman who was presented to a GP for review of her diabetes. So she was started on metformin 3 months ago. HbA1c is currently 53, and she's getting some abdominal discomfort and diarrhea. So what is the most appropriate next step in her management?
Aaron, can you see the poll?
Yeah, I can see the poll, yeah.
Fantastic, all right.
Okay, we'll get 10 more seconds. Okay, so let's stop the poll. And most of you have said B, which is swapping metformin for modified release metformin. So that is the correct answer. So if we just go through the answers, so A, so HbA1c is 53. So her diabetes isn't adequately controlled. So usually we're, anything above HbA1c 48 is classified as diagnosis of diabetes. And usually when we're offering monotherapy for diabetes, we aim for 48 as a target. So we want to keep her on at least one form of diabetes treatment. So she's got some abdominal discomfort and diarrhea. So one of the most common side effects of metformin is GI side effects. So if the patient's not being able to tolerate these GI side effects, then we can swap her from metformin to modified release metformin, and in most cases this should help resolve the symptoms. If they aren't able to tolerate even modified release metformin, then we can consider swapping to an alternative monotherapy. So that's where answer C would come in, something like linagliptin. So answer D, adding on linagliptin to metformin, this would be something we'd consider if her HbA1c wasn't being well controlled even on metformin. So usually we use a threshold for about 58 on the HbA1c before we add on another line of treatment. And lastly, 1 second. Wait. And swap, and that's why also we won't change to E yet, because we're not adding on the second line of treatment. Okay, so let's move on. Yeah, so B is the correct answer in this case. So we'll talk now about diabetes in general. So as I said, diabetes has a number of definitions now. So usually for a diagnosis of diabetes, you need to have usually one of these criteria and the patient being symptomatic, or two of those criteria and they're non-asymptomatic. So fasting plasma glucose of more than 7, more than or equal to 7, plus plasma glucose, which 11.1 or more after a oral glucose tolerance test, or HbA1c of more than 48 millimoles, that being the newest criteria. So when I started medical school, that was actually not a diagnostic criterion that could be used, but it has been introduced over the past couple of years. So now, and just before I move on, just to talk about two what we call at-risk diabetes states. So these are the people with impaired glucose tolerance or impaired fasting glucose, don't have diabetes yet, but they're considered at risk of diabetes. So these people you'd want to be targeting with interventions such as encouraging weight loss, looking at their diet, and trying to make sure that they're not progressing on to getting full-blown diabetes. So these are people with plasma glucose of more than 7.8 but less than 11.1 on a oral glucose tolerance test, or HbA1c between 42 and 47. As you can see from the statistic, they do have quite a significant risk of developing type 2 diabetes in the years ahead. And then the other definition that sometimes uses impaired fasting glucose, which is where they have a plasma glucose of more than 6.1 but less than 7. So this is a fasting sample. So they also have an increased risk of going on to develop diabetes, not as high as those with impaired glucose tolerance, but still pretty significant. Okay. So diabetes, so talk about the cause of diabetes. So broadly, diabetes can be classified, as most of you should know, into type 1, type 2. Type 1 diabetes is autoimmune destruction of your beta islet cells, which are responsible for endogenous insulin production. So that means the patient is reliant on insulin externally to meet their requirements. So typically this is in young children and young adults, associated with HLA D3 and D4. And as I said here, there's a 30% concordance in identical twins. So there is the genetic component, but interestingly, type 1 diabetes has less of a genetic component than type 2 diabetes. Some people hypothesize that it could be that the autoimmune event can be triggered by something like a viral infection, but truly the exact etiology is still not clear. And because it is an autoimmune disease, it is associated with lots of other autoimmune diseases. So your autoimmune thyroid disorders, like we talked about last time. So it's important those could also be coexisting. So type 2 diabetes, by far the most common form of diabetes, is by definition where you have insulin hyposecretion relative to the level of insulin resistance in the body. So that all that means is your insulin production is not enough for the level of insulin resistance that you have. So that means you either need extra insulin to potentiate the effects of the insulin, or you need something that will increase insulin secretion to meet the demand. So this is usually occurs in adults, but as obesity is becoming far more widespread across age groups, it's becoming a lot more common in younger people. Risk factors, in addition to obesity, are Asian ethnicity and elderly, because pancreatic function naturally decreases with age. And as I said, it has a very strong genetic component, so 80% concordance in identical twins. So then there are other causes of diabetes which don't fit quite neatly into type 1 or type 2. So most commonly is drugs. So patients on steroids can develop diabetes. Steroids naturally increase insulin resistance levels in the body to increase glucose release. This is a natural stress response. There's more glucose available for tissues to use in your stress responses. However, in patients with exogenous steroids, it can cause them to develop diabetes when they wouldn't otherwise. So with patients, especially with COVID patients now, a lot of them are on dexamethasone courses, and some of them can develop hypoglycemia transiently during that time. Other drugs that can cause it are newer antipsychotics, so things like olanzapine. Thiazide diuretics can sometimes cause it, and also HIV drugs. Another major group of patients who can develop diabetes are patients with pancreatic disease, so pancreatitis, more commonly chronic pancreatitis, iatrogenic things such as surgical removal of the pancreas, and other diseases such as pancreatic cancer, or any disease such as hemochromatosis, where you get iron deposition in the pancreas, and which leads to its malfunction. Finally, endocrine diseases, so Cushing's disease for the same reason that steroids would cause hypoglycemia, but also other states such as acromegaly can cause hypoglycemia, Theo's, hypothyroid, and finally pregnancy, so gestational diabetes, which I won't talk about in this talk, but it's something that's quite relevant for obstetrics. So how do diabetes patients present? So type 1 diabetes patients can usually present with increasing fatigue. They'll be losing weight because of the lack of insulin. Their body treats themselves as if they're in a starvation state. So they start using up their fat stores and eventually move on to their protein stores as a source of energy. Even though they do have glucose available, they're not utilizing it. Patients often have polyuria and polydipsia because they're hypoglycemic. And if they're at an extreme state, then they can develop ketosis. They may present with DKA, so they have characteristic sweet-smelling breath, and if it's more extreme, then they can be in full shock with vomiting and severe abdominal pain. Type 2 diabetes, the presentation is often a lot more insidious. They're usually very asymptomatic until they present with the complications of diabetes itself. So they'll have visual problems from diabetic retinopathy. They might have the presentation of peripheral neuropathy, so paresthesia, loss of sensation. They can present with initially with chronic kidney disease, cardiovascular disease, ulceration, or because of their hypoglycemic, they're more prone to infections. They may develop infections, particularly fungal infections. Although there are some cases where type 2 diabetics can present similarly to type 1 as well, with polyuria and polydipsia. So investigations for diabetes. So as we said, to meet the definition of diabetes, we need to look at their plasma glucose, ideally fasting, also with all glucose tolerance tests and HbA1cs. We want to look at whether they have any risk factors or complications of diabetes already. So looking at their using these to see if they have how their renal function is, and looking at their lipids to see whether they have hyperlipidemia, so if they've got other factors of metabolic syndrome. We want to look at their urine dip, again, to look for, and urinalysis, again, to look for whether they have any evidence of diabetic nephropathy. And finally, if you're unsure about what type of diabetes it is, which is becoming a lot more common now, as there's a lot more of an age overlap, so we can do tests to confirm different types of diabetes. So most commonly, we'll be looking at antibodies, so anti-islet cell and anti-GAD antibodies are usually positive in type 1 diabetes. And we can also look at their levels of plasma insulin and C-peptide to see whether they're actually secreting any insulin. If the body is not secreting any insulin, then their C-peptide levels will be low and their plasma insulin will be low. And C-peptide is co-produced with insulin and is a product of the post-transcription modification of the protein. Okay. So just to mention before I move on that there are obviously other types of diabetes, such as your MODIs. Those things are quite niche, so you probably won't need to know much about them, and I won't be covering those in this talk. It's just more important you know about your type 1, type 2 diabetes. So diabetes management, there are a lot of aspects to management. So this is just an overview of the general management of how you'd manage any patient with diabetes, whether it's type 1 or type 2. So first thing is education. So the patient needs to know about their diabetes and how best to control their diabetes. So it is very much an MDT approach with input from nurse specialists, dietitians, and also there's various support groups who can advise these patients. One major aspect of diabetes management is lifestyle, and this is usually the first stage of management for all patients. To advise about diet and also about exercising. So important with diet is that they have low saturated fats and low refined sugars, but higher levels of complex carbohydrates and a moderate protein in their diet. It's important that most patients should be on a statin, so all type 2s with age over 40 should be on the statin because of their increased cardiovascular disease risk, and those in type 1 diabetes with some level of nephropathy those with a family history of cardiovascular disease, and those over the age of 35 should also be started on a statin. Blood pressure control is important to help minimize risk of cardiovascular disease and also renal disease. So I've listed some targets here. So it's important that we usually aim for a lower blood pressure target in those with end organ damage or renal disease. And with patients without those, we usually aim for a slightly higher blood pressure target to be below. Foot care is important. As I said, diabetes patients are at risk of peripheral neuropathy and ulceration, so it's important that their feet are inspected regularly, either in clinic or by podiatrists, to make sure that there isn't any development of either infection that the patient's unaware of or ulceration. Driving is important to consider, especially if the patient is prone to hypos, and the DVLA may need to be informed. They need to be regularly reviewed with a definitive HbA1c target, and that will be reviewed every usually 3 to 6 months. It's important that we monitor for the complications, and the patient is also told how to monitor their glucose at home, and they know when to recognize that their blood sugars are either too high or too low, so they can adjust their treatment if they are able. So type 1 diabetes, because it is a state of absolute insulin deficiency, they need to have insulin to replace the insulin that is missing. So they have quite stringent monitoring of their blood glucose. Usually we aim for at least 4 times a day, and we usually want them to have a plasma glucose fasting of 5 to 7 in the morning, and usually 4 to 7 between 4 meals. And the HbA1c, as I said before, we aim for a target of less than 48, and we can adjust their insulin dose usually by 2 to 4 units at their reviews to try and meet these targets. In terms of insulin, there's a number of different regimens that are available. So the most common one now is the basal bolus regimen. So usually they'll have usually either 1 or 2 long-acting insulin injections a day, and then they'll have a short-acting insulin around their mealtime to take into account how much carbohydrate they're consuming during their meals. This also means that they can also adjust their insulin depending on how much activity they have during the day. Obviously, if they are doing exercise, then they may take more carbohydrate in earlier on, and they may need to adjust their insulin to compensate for that. Another regimen that's often used in more elderly patients, so those who aren't able to manage their diabetes themselves as well, or those who have more rigid lifestyle structures, is just twice daily pre-mixed insulins that contains both long-acting and short-acting. And finally, sometimes in younger patients or those who struggle to maintain good diabetes control and often have frequent hypoglycemic episodes, something that can be done is insulin pumps. So these replace the daily injections of insulin, and they make sure that the patient has a regular supply of insulin during the day, and that can be bolused around meal times, taking into account how much they're eating. An important thing to state with diabetes injections is that it's important that the patient rotates their site to prevent lip atrophy at the site of injection. So usually common sites include points such as the deltoid muscle in the thigh and also in the abdomen as well. Type 2 diabetes management. So as we said with general management, first line is lifestyle intervention. And if they're not able to maintain a HbA1c of less than 48 with lifestyle intervention, then we would start them on metformin. As I said with the SBA before, if they're not tolerating metformin, we can switch to modified release. And if they're not tolerating that, we'd consider an alternative monotherapy from any of the other drugs that can be used. If they are on metformin, if they're on monotherapy and their HbA1c is rising to more than 58, then we'd want to add on a second line drug. There's a lot of different options available now. So we have Dpp4 inhibitors, which inhibit the breakdown of GLP-1, which is naturally released by our body after meals and potentiates insulin release. So this will prolong the action of GLP-1 and increase insulin release. We have pioglitazone, which is less commonly used now. It is an insulin sensitizer, but it is considered it causes fluid retention, so it is a risk for patients who have cardiovascular disease or pre-existing heart failure. It's also been shown to increase risk of bladder cancer as well, so it's not used as much anymore. Sulfonylureas are a quite common second-line diabetes treatment. So these potentiate the release of insulin from beta islet cells. Important thing to note is because they do potentiate the release, they are associated with a risk of hypoglycemic episodes. And finally, the newest drug that is available, only really that's been introduced over the last couple of years, is Sgl2 inhibitors. So these reduce the reabsorption of glucose in the kidneys, so these patients actually would urinate more glucose. So studies have shown that these are almost as good, that these are almost, if not better, than Dpp4 inhibitors in patients with cardiovascular disease, and outcomes from trials so they're actually quite good at reducing mortality and morbidity from cardiovascular disease in the long term, as with Dpp4 inhibitors. Sgl2 inhibitors are, because they do produce glycemic urine, are increased risk of UTIs and fungal urine infections. But more recently, something that has been noticed is that some patients can actually develop ketoacidosis on Sgl2 inhibitors. That's something that is being monitored. And so just before, just going back to Dpp4 inhibitors, as I said, they do have quite good cardiovascular effects. They're quite good for patients with cardiovascular disease. In rarely they have been associated with pancreatitis, but there's not really that much of a significant relation. So with most of these medications, we're aiming for the patient to have a HbA1c level of 53, particularly if they are drugs like sulfonylureas, which can cause hypoglycemia. Otherwise, we can sometimes aim for a lower target of 48 if they're on other drugs such as insulin sensitizers. If it's rising again to more than 58, even on dual therapy, we can add a third drug on, so any of the drugs which haven't been used already, or we can consider the patient for insulin treatment. And if triple therapy is not effective, or we can't use it for any reason, then what we can do is we can consider a triple therapy with metformin, sulfonylurea, and a GLP-1 mimetic. So something like Exandin, which is as a GLP-1 mimetic. And these are particularly useful in patients who have a high BMI, so more than 35, because they can actually help produce weight loss. So GLP-1 mimetics do have an influence on appetite and body metabolism, and can cause reduction in appetite and also weight loss. They're quite good in that respect, as well as with the Dpp4 inhibitors. They also have a good effect on cardiovascular risk. They can also be used in patients with a BMI of less than 35, where it's felt that they are at risk of obesity-related comorbidities, and it would benefit them. So let me see, I think there's a few questions. I'll just have a look at this when we want. So if someone is on dual therapy, HbA is once well controlled at around less than 48, would you consider switching back to metformin monotherapy? So that is something that can be considered. So you can step down as well as step up on the treatment ladder if you deem it necessary. Usually, if the HbA1c is well controlled at less than 48 and the medication is not doing them any harm, then usually you can just keep them going on the dual therapy. It's only if the HbA1c is coming quite low, below 48, then you would consider, are they at risk of actually developing hypoglycemic episodes, and is it worth stepping down? Okay, so now we're just talking about some of the complications of diabetes. So retinopathy and nephropathy. So it's important that patients have annual retinal screens. So these are both examples of microvascular disease. So hyperglycemic states are naturally pro-inflammatory, and particularly in small microvasculature, they can cause inflammation, and this can actually cause destruction of these small vessels. So, and in some patients, they're diagnosed, especially with type 2 diabetes, where they're asymptomatic. Some patients can be first diagnosed with type 2 diabetes purely because of evidence of retinopathy when they go for an eye checkup. So the first stage of retinopathy is background retinopathy, which you can see in the top picture. So they have evidence of microaneurysms, which are those dots you can see, and hemorrhages, which are those more spread out blotches of red, and hard exudates, which are very well demarcated yellow spots, so they represent lipid deposits. If usually these can be just monitored, but if they have evidence of this near the macula, then they will need to be referred for treatment. Pre-proliferative retinopathy is the next stage along, and because of extensional destruction of these microvessels, they can develop retinal ischemia. So they develop these cotton wool spots, which are these more fluffy looking yellow spots, as you can see on the diagram, the second diagram down. They can also develop more drastic hemorrhages and also some evidence of bleeding on the venous vessels in the retina. These will need to be referred to a specialist for treatment. And if it is very extreme, then they can develop proliferative retinopathy, where the ischemia is so severe that the body responds by releasing VEGF, which is a vascular growth factor, and this stimulates new vessel formation. So this will also need to be treated. So when I say treatment, so the treatment for retinopathy is laser photocoagulation. So this will stop any new vessel formation, which could impair vision. And if it's maculopathy, then they often need more localized treatments. So can be with a laser photocoagulation, can be with intravitreal steroids, or can be with anti-VEGF agents, which again are designed to stop these new vessels forming, which can lead to obstruction of the vision if they're impacting on the retina. Yes, sorry. So the bottom image does show proliferative retinopathy. So as you can see, they have lots of new vessels forming. So now, if we move on to the next complication of diabetes, it's nephropathy. So similar mechanism, it's a pro-inflammatory state of the glomerulus in the kidneys. So this can cause the glomeruli to become leaky, and you get microalbuminuria. So you get a urine albumin creatinine ratio when you analyze urine of more than 3 milligrams per millimole. So this is a sign of early kidney disease. And usually when we see this, we want to try and stop this progressing further. So we'll start them on usually quite tight blood pressure control and an ACE inhibitor to reduce the progression of the nephropathy. So what you can notice is that when you start an ACE inhibitor, the renal function will actually initially decline, but then it will eventually plateau out. So even though you start the ACE inhibitor and there is quite a sudden decrease in renal function, this isn't something to be concerned about. This is something that does happen. But in the long term, this does suppress the overall chronic reduction in their kidney function. If their albumin creatinine ratio does go above 7 milligrams per millimole, then they will need to be referred to renal physicians, and they probably will need to be further followed up to manage any further progression of their kidney disease. Okay. So next we have diabetic nephropathy. Again, so similar mechanism to the other two, but where you get this hyperglycemic inflammation affecting the vasa nephrorum around which supply your nerve bundles. So it can present in a number of different ways. So mononeuritic multineuritis multiplex. So this is where you get lesions of 2 or more individual peripheral nerves. So, and they're usually quite distinct. So usually these can be monitored. If it is a quite sudden or severe development, then you can try immunosuppression initially. Secondly, amyotrophy. So this is painful wasting of your quadriceps and pelvic girdle muscles. And usually there's not really any treatment for this. There can be a gradual improvement in this over time, but it's usually incomplete. The most common complication of this neuropathy is sensory polyneuropathy. This can usually present as loss of peripheral sensation, but it can also cause neuropathic pain. So there's a number of treatments that can be given. So initially you want to try paracetamol. If that doesn't work, we can try our neuropathic pain treatments. So things like amitriptyline, gabapentin, and then moving on to opiates if none of those are successful. And finally, autonomic neuropathy. So where the neuropathy is affecting both sympathetic and parasympathetic nerves. So we lose the function of those. So it can cause diarrhea nocturnally, can cause problems with bladder emptying, so urinary retention, can cause gastroparesis, so delayed gastric emptying, so can present with the post vomiting after you've eaten, and constipation. So this can be diagnosed by looking at by a technician follow-through meal, and can be treated with prokinetic agents. So it's things like metoclopramide and erythromycin are both prokinetics that are used. Erectile dysfunction can be treated with so Viagra, sildenafil, and orthostatic hypotension. So if we're not getting vasoconstriction of venous return when a patient stands up, then they can get postural drop. So can be managed by initially getting them to increase their salt and fluid, and with pressure stockings. And if this isn't working, we can try fludrocortisone and midodrine, which are designed again to retain more salt and more fluid in the case of fludrocortisone, or in the case of midodrine to encourage the vasoconstriction. So the diabetic foot is the manifestation of a number of these vascular complications and neurological complications. So it's important that we regularly assess their feet for both signs of ulceration, their pulses, sensory function, to look whether there's any deformities in the foot. So the diabetic foot can be classified as either neuropathic or ischemic. The neuropathic feet, their pulses are still present. The feet are often warm and dry, and they have signs of ulceration, usually at high pressure points. So these are on the ball of the foot and also on the heel. They often have sensory loss, absence, ankle jerks because of this, the loss of the nerves in the feet. And if they have chronic sensory loss, they can develop neuropathic deformities. So more commonly known as Charcot's joints. And this is because they lose sensory sensation in their foot. So they often cause trauma to their foot inadvertently in microfractures, which they don't notice. And over time, these heal aberrantly, and these lead to deformities of the foot themselves. So it's important that they inspect their feet daily, they wear comfortable shoes, and they avoid walking barefoot, because if they were to stand on something, they wouldn't necessarily be able to feel it. On the other hand, we have the ischemic foot, and this is often a manifestation of macrovascular disease rather than microvascular disease. So atherosclerosis of the major vessels supplying the lower limb, leading to reduced perfusion. So we have their pulseless, they're cold, and they have ulcerations at the peripheries of the feet, where circulation is poorest. So it's important that if the pulses are not palpable, that a Doppler assessment is done to see whether there is circulation to the feet. And if it is extreme and they do have ulceration, then they will need to have revascularization surgery to restore perfusion to their feet. So how do we treat ulcers in diabetic foot? So make sure that regular chiropody to remove any calluses, because infection can develop beneath the callus. Make sure, as I said, make sure they're wearing comfortable shoes to relieve pressure on high pressure areas. If there is evidence of infection with the ulcer, they need to have antibiotics. Usually they will need IV antibiotics, and they may need surgery if there's a deep infection that needs debridement. If they have evidence of severe infection like gangrene, if they have evidence of infective or septic arthritis from the secondary to this infected ulcer, or if they've got rest pain. So that would indicate that they have critical limb ischemia and they will need urgent revascularization. Sick day rules, very important for diabetic patients, especially those with type 1 diabetes. So if they are unwell with any sort of infection, it's important that they drink plenty of fluids. If they're not able to eat, that they try and maintain calorie intake through some means, whether this is by milk, soups, fizzy drinks, or fruit juices. Monitor their glucose at least 4 times a day, if not more. And they need to seek urgent medical attention if they're persistently vomiting, so they're unable to keep fluids down, they're very hypoglycemic or hyperglycemic, or they're becoming drowsy or confused, because this could be a manifestation of early DKA. If they're on insulin, then their insulin requirement may actually increase because of their stress response. They can become hyperglycemic. And if they become very hyperglycemic, then they may need to have an insulin dose increase, or they may need to seek medical attention. And finally, if they have ketone positive in their urine, then they will also need to seek medical attention because they could be having an early DKA. And if they're type 2 diabetic on tablets, usually they'll keep their normal medications going, but if they are profoundly dehydrated or septic, then they will need to have their metformin withheld because they are prone to lactic acidosis. Okay, so that's type 1, type 2 diabetes in a nutshell. So we'll just do another SBA now. I got there before we do this one question, I think. Okay, no, it's not. Okay, so we'll go through this SBA now. So a 35-year-old man is brought by ambulance to the emergency department with severe abdominal pain, vomiting, drowsy, and glucose 16. Ketones are also elevated. He's profoundly hypertensive and a bit tachy. So what would be initial fluid management for this patient? Okay, give you another 10 seconds. Okay, so we'll stop there. So the answer, most of you put the answer as A, and A is the correct answer. So this patient is presenting with classical diabetic ketoacidosis, DKA. So they've got severe abdominal pain, vomiting, and they're very drowsy. They're hyperglycemic, blood glucose is more than 15. Ketones are elevated, capillary, very hypotensive. So they're hypotensive and they're slightly tachy. So according to management from Diabetes UK, we usually only give initial fluid bolus, so the 500 mils over 15 minutes, if their systolic blood pressure drops below 90. This is not the case here, so we wouldn't need to give a fluid bolus of 500 mils immediately at this time. But it is obviously something to keep an eye on, that if their blood pressure does drop below that level, you would give that bolus. So if we follow the diabetes DKA management guidelines, the first bag of fluid should be 1 liter of sodium chloride over 1 hour. So that's why A is correct. So B is 1 liter with 40 millimoles of potassium. So 40 millimoles, so the potassium would not be added until at least the second bag of fluid, according to guidelines. And again, that would be dependent on what their blood serum potassium levels are at that time. So that's why that's not the correct answer. So 1 liter bag over 2 hours, so that would actually be what the second bag of fluid would be, 1 liter over 2 hours. And 500 mils over 1 hour is not correct because it should be at least 1 liter over the first hour because they are going to be quite dehydrated. Okay, so we're going to talk now about some other acute diabetic complications. So firstly, DKA. So diagnosis of DKA is a triad of acidemia, so pH of less than 10.3 or bicarb of less than 15. They're profoundly hypoglycemic, so blood glucose of more than 11, or they're known diabetic, and they have either ketones of more than 3 on capillary ketone measurement or ketones of +2 or more on a urine dipstick. So there are a number of different triggers for DKA in these patients. So if they have the wrong insulin dose and not compliant with their insulin, if they've had recent infection, recent surgery, or recent MI, if they develop pancreatitis, if they're on, and if they've taken any drugs which can cause DKA as well. So some chemotherapy drugs and some antipsychotics can also trigger DKA. But by far the most common ones are in patients who've had a recent infection or they've had a incorrect insulin dosing. So how do they present? So some of it was highlighted on the picture in the previous slide. So, and what we talked about earlier with ketosis. So there'll be vomiting and severe abdominal pain, usually polyuria and polydipsia because they're profoundly hypoglycemic and they have a high serum osmolality. Very drowsy, very poor appetite, and this ketotic breath, so very sweet smelling like pear drops is characteristic. Very dehydrated, so they'll be very tachy, hypotensive, and if it's extreme, they can be in a coma. And they have this sighing Kussmaul's hyperventilation. So this is because they're trying to blow off carbon dioxide in an effort to combat the profound acidemia. So how do we investigate? So initial investigations will include ECG, chest X-ray. So ECG to look for any recent MI as a trigger and assess their cardiac function because they are going to be tachy, so they may have developed an arrhythmia. Chest X-ray to look for any signs of infection, which can be a precipitant. And ECG, ECG is already done. So that's a repeat there. They need a urine dipstick and MSU. Again, check for the ketones, check for glucose, and also check for signs of infection, urine. They will need blood. So initially, a capillary blood test is important for both ketones and glucose, as I said before, and then lab bloods for glucose for their and for the other markers such as using these, their bicarb, serum osmolality, and full blood count. Also useful to take some blood cultures to look for any signs of sepsis. And they also will need an arterial blood gas or a venous blood gas regularly to monitor their using their ketones and their pH levels. Just one question in the chat. So the ECG, I guess, well, that's just a typo. So it just looks like the text is repeated. So you just do ECG, chest X-ray, urine dip, and then your bloods. So another question. So So MSU is midstream urine. So it's important. So when you're looking for urinary tract infections, we take a mid-urine stream sample to make sure that there's no contaminants, and the urine is a reflection of the urine that's in the bladder at that time. So talking about the management of DKA. So as I said, systolic blood pressure is less than 90. You'd give an initial fluid bolus of 500 mils of crystalloid of your choice, either sodium chloride 0.9% or Hartmann's can be used in some cases over 15 minutes, and a further fluid bolus if BP still remains less than 90. If it's still less than 90 after 2 boluses, you'll need to involve ITU because they will probably need inotropic or vasopressor support. If the systolic blood pressure is more than 90, then we follow guidelines. So initially 1 liter of sodium chloride over 1 hour. And concurrently, we'd infuse insulin at a rate of 0.1 units per kilo per hour. and we're aiming for a drop in ketones by 0.5 millimoles per liter over an hour, a rise in bicarb by about 3 millimoles per liter per hour, and glucose also falling by about 3 millimoles per liter per hour. If they are a known diabetic patient and they're on long-acting insulin, then it's important that long-acting insulin is continued even when they're having the insulin infusion. And we regularly take their capillary glucose measurements, and we regularly take blood gases to measure their blood glucose and ketone levels hourly. So the VBGs are done initially 1 hour, 2 hours, 4 hours, 8 hours, and with increasing intervals. And we continued bags of 0.9% sodium chloride, initially 1 litre over 1 hour, as I said, then 1 litre over 2 hours, another litre over 2 hours, and then we're increasing the intervals that we're giving the bags over. So we check the capillary glucose regularly, but we also want to check lab glucose because it's a more accurate representation. So while capillary glucoses are good, sometimes they're not wholly accurate. That's why we also need to keep an eye on their lab blood glucose as well. But capillary glucose would be done, can be done more frequently at the bedside and give us a more accurate representation of what's going on. Okay. So another thing to consider with these patients is their potassium requirement. So remember that insulin is used in the treatment of hyperkalemia because it does actually drive potassium into cells. So you do need to take into account their potassium requirements. We don't add potassium into the first bag of fluid, but after that we add potassium based on their serum potassium levels in their first bloods. So if it's more than 5.5, we don't add any potassium. It's 3.5 to 5.5, we add 40 millimoles per liter of fluid. And if it's less than 3.5, then they'll probably need more intensive potassium support. So they'll probably need ICU advice because higher levels of potassium infusion usually need to be done via a central line. Because they're profoundly dehydrated, this is a procoagulant state, so they will need to be started on low molecular weight heparin or other anticoagulants. And it's important we monitor their urine output, so aiming for about 0.5 mils per kilogram per hour. So in an average sized adult, about 30 mils an hour urine, to make sure that they're adequately hydrated. Once their glucose starts dropping below 14, we want to start a 10% glucose infusion alongside everything else at 125 mils an hour. This is because insulin levels are still quite high and we don't want them going the other way and becoming hypoglycemic. And we continue the insulin infusion up until their ketone levels are below 0.6, their venous pH is more than 7.3, and their bicarb is more than 15. At this point, we make sure that they're eating and drinking, and if they've been eating and drinking fine, we can switch them onto subcutaneous insulin if that's what they normally take. Otherwise, we can put them onto a sliding scale if they don't usually take subcutaneous insulin or if they're not able to eat orally yet. So someone just asked about why they're hypercoagulable. So dehydration means that they're more prone to forming clots. It's simply why. Okay, so Dka complications. So Dka can be very severe, and it may need, and if it meets any of these criteria for severe Dka, then they'll need to be taken into HD or ICU for more intensive care. So if they're very acidotic or they have very high ketones, if their potassium is quite low, or if they're not able to maintain adequate oxygenation, adequate blood pressure, or their GCS is less than 12. Other complications that can occur, so you can become hypokalemic or hypomagnesemia or hypophosphatemia, just because that insulin can cause those when we're giving it high doses. As I said, VTE can occur because dehydration is a procoagulant state, so VTE prophylaxis is given. They can develop aspiration pneumonia just because if they are drowsy and they are taking oral intake, they can aspirate. And if they are vomiting, they are prone to aspiration. And finally, because they're very dehydrated and we're giving them fluid, this can cause sudden fluid shifts if we give the fluids too quickly, which is why we have this weaning of fluids and we're giving it over a longer period of time so that we don't develop cerebral edema. The next, we'll talk about the hypoglycemic hyperosmolar state, which is the acute diabetic emergency, which typically affects type 2 diabetic patients. So the triggers for this are very similar for triggers for DKA, so sepsis, infections, MI, recent surgery, trauma, or any acute illness. And this, so what HSS basically is if they have very severe hypoglycemia, and this can cause profound dehydration. But because they still have a level of insulin production type 2 diabetes, this suppresses ketogenesis, so they don't develop ketoacidosis. So it can present similar to DKA in that they are very drowsy, lethargic, they can be polyuric and have polydipsia. However, they don't have any of the ketosis features typically. So as I said, very hyperglycemic, usually more than 35 millimoles glucose. Their ketones, so their ketones are less than 3, so normal blood ketones, and they're not acidotic. They're very dehydrated, so they have a very high serum osmolality. So, and you'd want to monitor, so you do your routine blood, so your full blood count, you're using these. And you want to look at whether there's an underlying cause. So looking for signs of infection with, as I said, with midstream urine for cultures, blood cultures, ECGs, and chest x-rays as well. So in terms of management, so the key is rehydrating them. Again, we rehydrate the patient slowly so we don't get sudden fluid shifts. That puts them at risk of things like cerebral edema. So you want to rehydrate them with crystalloid, usually over about 48 hours. And we replace their potassium, if they do need potassium, as per the DKA guidelines. We want to keep their blood glucose initially at least 10 to 15 over the first 24 hours, as I said, because we don't want these sudden fluid shifts causing cerebral edema. Again, because they're very dehydrated, they need DVT prophylaxis with low molecular weight heparin. They will need their using glucose and osmolality measured, usually every 2 hours. And we try and avoid insulin unless their blood glucose is not falling by 5 millimoles per liter initially over the first hour following rehydration, or if they do develop signs of ketonemia. That is HSS in a nutshell. Most different trusts will have their own guidelines about the fluid requirement and how fast they give it over. Okay, so that's diabetes done. So we'll move on to the next topic. So starting with an SBA, a ward doctor is asked to review a 65-year-old man with type 1 diabetes and liver cirrhosis who has become more drowsy and he appears thin and malnourished. Pre-glucose 2.4, his cannula is tissued, so he cannot be used currently. And what's the most appropriate management? Okay, I'll give another 10 seconds. Okay, we'll close the poll there. So most of you put the answer as C, intramuscular glucagon 1 milligram. So the answer in this case, so we would still want to try and give IV glucose as our first line management in this case. Why? Because this patient has liver cirrhosis. If they've got a cirrhotic liver, this means that their liver would not have its usual glycogen stores. So this means giving them glucagon wouldn't be able to release any glucose stored in the liver. So giving them glucagon wouldn't actually have that much of an effect on their serum glucose. So we would need to try and get another cannula in and give them IV glucose, 100 ml, 20% as a stat dose. That's why glucagon IM or subcut is not the correct answer in this case, because there's not the stores of glucose in the body to release or make available. We wouldn't want to give glucose over 4 hours because that's too slow to take an effect. 10% isn't high enough concentration. And 15 glucose orally wouldn't be used because he's drowsy. He wouldn't be able to take oral glucose. And someone's got a question. So from the last case, how would you actually quantify osmolality? So serum osmolality Serum Osmology is a test that is available. Most labs will run it. So this usually takes into account, yes, so someone's replied that anyway. So you would take into account your serum sodium, and so serum sodium, serum potassium, urea, and glucose. And this is combined together. And this is combined together to give you an idea of what the osmolality is, but but you wouldn't have to calculate this most cases. You wouldn't have to calculate this yourself. Most labs can actually run it themselves based on the serum samples that they analyze. Okay. So we're now going to be talking about hypoglycemia. So hypoglycemia, there are various definitions of what is hypoglycemia and what the cutoff is. You'll see lots of different numbers, but most common number is less than 4, being the criteria for hypoglycemia, but you may see other numbers based on where you're looking. Most likely causes excess insulin or oral hypoglycemic agents being taken either deliberately or by accident. Another common cause of hypoglycemia is alcohol excess. But then there's a number of less common causes. So postprandial hypoglycemia, otherwise known as dumping syndrome. So this can be caused in patients with diabetic autonomic neuropathy or post-gastric surgery. And this is because in these patients you have increased flow of food through the GI tract. And this means more food and more nutrients are reaching the intestine faster. And this means you get a greater release of these hormones like GLP-1, which stimulate insulin release. So you get a much bigger level of insulin release a lot sooner than you would have done otherwise. And this can cause glucose levels to drop quite suddenly. As a liver failure, so in patients with cirrhotic liver and liver failure, because they don't have these hepatic liver stores that are available to be used, so they can become hypoglycemic. Adrenal failure and pituitary insufficiency can cause hypoglycemia because of the lack of cortisol, which again is responsible for causing glucose release from your body stores in fat, muscle, and in the liver. Sepsis can cause hypoglycemia, again because it is a stress state. Stress sepsis can cause hypoglycemia because if your body is stressed, it's using up more of its glucose stores to combat this infection. Very rarely, insulinomas, so insulin secreting tumors, can cause it, and other cancers. Salicylate poisoning, so overdosing on aspirin, can cause hypoglycemia, and very severe cases of malaria, so can cause hypoglycemia as well. So hypoglycemia symptoms can be classified in two groups. So it's adrenergic, so your activation of the sympathetic nervous system symptoms, so tremors, palpitation, sweating, and excess hunger, and your neurological symptoms from low blood sugar, so confusion, seizures, drowsiness, and coma. So how do you manage it? So if they have a low GCS, first line is 100 ml 20% glucose stat as IV dose. If you're not able to establish IV access, or they have an insulin overdose, then we can give intramuscular or subcut glucagon 1 milligram. But as I said before, if the patient is malnourished or is in liver failure, it's not suitable because they don't have the glucose stores in their body available to be released by glucagon. Once their glucose levels have been stabilized, you want to give a 1 litre bag of 10% glucose over 4 to 8 hours to keep their glucose levels above 5, and you want to monitor their glucose levels regularly until they're stable. If they are GCS 15, so they're not drowsy, you can give a 15 or 20 gram fast-acting carbohydrate. So some sugary drink or an oral glucose tablet or gel, and you'd want to again monitor their glucose levels. If they're still hypoglycemic despite 3 oral glucose loads, then you would move on to treat them as if they had low GCS, so using IV glucose or glucagon. And once they are recovered, you want to give them a long-acting carbohydrate to maintain their glucose stores, so something like a piece of toast or a biscuit. Okay, so next case, 52-year-old woman is on the tertiary ward and treated for a CAP. Her bloods show her sodium level is 128 millimoles per litre. Okay. She is euvolemic. Her TFTs are normal, and she has a short synaptic test performed, which has no abnormal response. So how would I manage this patient initially? Okay. Okay, another 10 seconds. Okay, let's stop there. So most, you said the answer is A, 1 litre over 24 hours as a fluid restriction, and that is the correct answer. So this patient is presenting with, so they're hyponatremic and they're clinically euvolemic. TFTs are normal and short-acting test is normal as well. So the most likely diagnosis in this case, which I'll come on to later, is syndrome of inappropriate ADH secretion, so SRADH. And this would be initially managed with fluid restriction to try and get that sodium level back up. 500 mils of 0.9% sodium chloride 15 minutes is not correct. That would be the management of hyponatremia if this patient was hypovolemic. So you're fluid resuscitating them to restore their circulating volume and giving them sodium as well. Okay, 500 demeclocycline is an ADH receptor antagonist, and this would be used this would be used if the patient is not responding to a 1 litre fluid restriction. Tolvaptan, I'll come on to later, again, is another treatment that can be used in SRADH that is not responding to fluid restriction. And 1 litre of sodium chloride over 1 hour just isn't the correct option for any of in hyponatremic patients. Okay, so one question. Yeah. So this patient has SIADH, and it is secondary to their pneumonia. So I'll come on to why that is in a second. So hyponatremia in general. So when you are looking at a patient who's hyponatremic, you need to think about what is the underlying cause, as that will determine what the management is. So you want to clinically assess the patient to see whether they're hypovolemic, if they're euvolemic, or they're fluid overloaded, so hypovolemic. And that will tell you more about what the cause is. So hypovolemic causes are if they're losing excessive fluid through diarrhea, vomiting, or having diuretics, or salt losing nephropathy from the kidneys, because they're losing a disproportionate amount of fluid compared to their salt loss. So sorry, they're losing their fluid and their salt. But what happens is when this happens, your body responds by causing your vasopressin levels to increase. But this only will retain fluid rather than salt. So you become hyponatremic. In euvolemic patients, the cause of hyponatremia can be things like hypothyroidism, adrenal insufficiency, SIADH, or if they've had excessive fluids. So either 5% glucose IV or they're drinking too much orally. And the last group is your fluid overload patients, those with cirrhosis, renal failure, nephrotic syndrome, or heart failure. So how does a hyponatremic patient present? So a hyponatremic patient usually can present with any of these things. So very non-specific: nausea, anorexia, irritability, confusion, drowsiness, reduced GCS, and seizures, just to name a few. So it is quite non-specific presentation. So assessing a patient, so if they're hypovolemic, they will usually be tachycardic. Initially will be possible to show postural hypotension, but if they're very dehydrated, then this can just be hypotension even when they're lying down. Dry mucous membranes, diffuse skin turgor are classic signs of dehydration to look out for. If they're very dehydrated, then reduced urine output and confusion, drowsiness. And hypovolemic signs are signs of fluid overload. So peripheral edema, pulmonary edema, so biobasal crackles, and raised JVP. So how do I investigate hyponatremia? So you want to try and rule out what the causes are. So you do your baseline bloods, full blood count using these LFTs and inflammatory markers. You want to look at your plasma osmolality. So like we said before, you want to a number of different electrolytes and criteria will come to determine what the osmolality is. You'd want to look at your thyroid function test and also later on consider a Schultz-Actin test if you've ruled out hypovolemia and hypovolemia. And then urine, you also want to look at the urine osmolality as well to see how concentrated the urine is and your urine sodium levels. So if the urine sodium is more than 20 millimoles and they are hypovolemic, it's due to usually a renal cause, so diuretics, or can be due to Addison's. If it's less than 20 millimoles per liter, that means they're not losing the salt through their kidneys. So they're losing the salt somewhere else if they're hypovolemic. So diarrhea, vomiting, burns, small bowel obstruction, or hypothermia. So how do you manage hyponatremia? So we want to correct these sodium levels, and we want to aim for a rise in sodium by no more than 10 millimoles per liter in a day. And that's because if it rises by more than that, we risk osmotic shifts causing osmotic demyelination of the central nervous system. So this can cause central pontine myelinolysis, and this can be quite detrimental to the patient. So they can become paralyzed with quadriplegia and other bad things like seizure, coma, and eventually death. If they're hypovolemic, we want to replace this sodium along with volume of fluid. So we give 0.9% saline to correct their fluid deficits. If they're euvolemic, we want to give them fluid restriction. So we usually try and give them slowly sodium chloride, so about 1 litre usually over 8 to 10 hours, and treat any underlying cause. And if they're hypovolemic, the treatment is fluid restriction, and again treating any underlying cause. And if they're severe hyponatremia, as I said before, can manifest as reduced CCS and seizures, and this is usually when the sodium drops below 120. And if this happens, they will usually need hypertonic saline. So this usually has to be done in an intensive care setting under expert supervision. So SRIDH, this is where you have your, as basically in the name, you have inappropriate and unsuppressed release of antidiuretic hormone. And there's a number of criteria that need to be met before you can diagnose it. So no hypovolemia, and they're not fluid overloaded as well. They've got no evidence of hypothyroidism or adrenal insufficiency. There are no antidiuretics. Urinary sodium is more than 20, and urine osmolality is usually very high, more than 100. And they have a reduced plasma osmolality because they're retaining fluid in their plasma. So there's a huge list of causes of SRIDH, but they can all be broadly categorized into CNS pathology, so tumor, trauma, infection in the central nervous system, lung pathology, so similar things, tumor, trauma, infections in the lung, drugs, huge number of drugs can cause it, so just name a few: antidepressants, opiates, PPIs, and carbamazepine. Tumors anywhere in the body can contribute to SRIDH, and any surgery can also be a trigger. So how do we treat it? So as most of you said before, fluid restriction, so usually 1 litre a day initially, and if it's not responding to that, we can give them ADH antagonists. So doxycycline is one that we can use to reduce the responsiveness of your collecting duct tubule cells to ADH. So we're reducing the amount of fluid that's being reabsorbed. And you need to monitor the use and use for that, because it can be slightly nephrotoxic. And one of the more newer drugs is tolvaptan, which again, similar mechanism of action, it's a V2 receptor antagonist. So someone's asked, you measure the decrease in serum osmolality or the increase in urine osmolality in SRIDH. So you'd be wanting to measure both, because both are giving you an idea of what is happening in the body. So you'd want to be looking for your urine becoming more dilute, so your osmolality decreasing in your urine and your serum osmolality increasing. So you're knowing that the treatment is working. Okay, so next question. An 82-year-old man admitted with acute diverticulitis, which is now settled. Daily blood show sodium is 152. Very common in surgical patients. This is on examination. He has poor skin turgor and dry mucous membranes. Blood pressure is 105/78. Urine and serum osmolalities are both elevated. So how would you manage him initially? Okay, 5 more seconds. Okay, stop that. So most of you said the answer is A, 1 litre of sodium chloride over 6 hours, and that is the correct answer. So this patient is hyponatremic, and they're clearly dehydrated. They're poor skin turgor and dry mucous membranes. But he's hemodynamically stable. Blood pressure is holding 105/78. So, and his serum and urine osmolalities are, again, they're both raised, so find that he is dehydrated. So how do we treat this? So we need to rehydrate the patient. So we give them 1 liter of sodium. So it's a bit counterintuitive to give them sodium chloride even though they're hyponatremic, but we're trying to, because they're fluid depleted, we need to restore their intravascular volume. And the best way to do this is to restore their intravascular volume using sodium chloride. So we give 1 liter of sodium chloride, but we give it quite slowly, so over 6 hours. So we're not causing that sodium to rise any further. So 1 liter of 5% dextrose over 6 hours would be the correct answer if this patient was adequately hydrated, because this would just be adding further, essentially, water to the body, so diluting that sodium. So 1 liter fluid restriction, as we said before, is a treatment for SIADH. So when the patient's SIADH, desmopressin again is the would be a treatment if the patient would not be treated in this case. And 500 mils 0% saline over 15 minutes would be a treatment if this patient was profoundly hypertensive, so systolic less than 90. That is not the case here. Okay. So hyponatremia. So hyponatremia causes by far most common cause of hyponatremia is when they're losing water that is not being replaced. So GI losses, so diarrhea, vomiting, sweat losses, so if they're pyrexic, like if they're unwell with fevers, or if they're losing fluid through burn wounds, renal losses, so osmotic diuresis, high glucose in urine, so diabetes, or as we said before, things like diabetes insipidus can cause it. Inadequate intake of fluid. This is particularly a common problem in elderly patients or patients with hypothalamic disease, because your hypothalamus is responsible for controlling your drive for thirst and appetite. And rarely it can be caused by excess sodium in the body. So this can be iatrogenic, so too much sodium being replaced, or Conn syndrome. So how do they present? Again, quite non-specifically, so it can be similar to hyponatremia, so drowsiness, weakness, confusion, seizures, but they are often thirsty as well. So how do we investigate this? So we need to rule out other reasons for them being dehydrated or hyponatremic. So we first of all measure their serum glucose. So we want to exclude diabetes mellitus. Serum potassium, because if they're hypokalemic, this, as I talked about last time, can cause diabetes insipidus. Okay, and that needs to be corrected if that's the case. Same with hypercalcemia, that can cause diabetes insipidus. We then you then want to assess whether they do have diabetes insipidus, so looking at paired plasma and urine osmolalities and doing a water deprivation test to assess this further with a CT or MRI if you suspect they may have central diabetes insipidus. So how do we manage hyponatremia? So slowly correct sodium like before, at most 10 millimoles per liter over a day. So if they are hypovolemic, we give them 1 liter over 6 hours sodium chloride to prevent sudden sodium shifts until they're normovolemic. And once they're normovolemic, we then either encourage them to have all fluid intake, or we give 5% glucose bags, 1 liter over 6 hours. And we monitor their fluid balance and their sodium levels in the plasma to make sure that they're coming down at the correct rate. Okay, obviously, if the cause is diabetes insipidus, then we'd want to manage them for diabetes insipidus as well, depending on whether this is central diabetes insipidus or nephrogenic. And I talked about that in my last talk. So SBA, another one for you. 45-year-old woman presented to a GP with long-standing constipation and recent onset new back pain. Feels thirsty and regular passing large volumes of dilute urine. Her bloods show a raised serum calcium, low phosphate, and normal pH. So what's the most likely diagnosis? Okay, give me 5 seconds. Okay, so most of you said the answer as D, multiple myeloma. So that's not the correct answer. The correct answer is parathyroid adenoma. And I know why most of you did say multiple myeloma, but I'll explain the reason why it's parathyroid adenoma. So they've got symptoms of hypercalcemia. So they've got constipation, it's got abdominal symptoms. They've got bony pain. They've got polyuria and polydipsia. They've got a high calcium and a low phosphate. And the key here is that they have a normal PTH. So if they have a high calcium, their PTH should be suppressed. The fact that it is not suppressed suggests that they have PTH secretion, which is not controlled by the calcium. So they have PTH secretion that is not controlled. So it must be from a PTH secreting tumor, so parathyroid adenoma. The reason it's not multiple myeloma is because if it was myeloma, yes, their calcium would be increased. Yes, back pain is a common presentation of it initially because you can get bony lesions in myeloma, but you'd expect their PTH to still be suppressed because their calcium is high, so by negative feedback, their PTH should be suppressed. So PTH, so this is so someone's asked, why isn't PTH raised in adenoma? It is raised because it's inappropriately raised, inappropriately normal. So a PTH should be suppressed in hypercalcemia. The fact that it's not is showing you that there is a degree of secretion that is not independent of calcium control. Okay, so sarcoidosis, so the other answers are all incorrect for the same reason. You would expect PTH to be suppressed in high calcium states, and it's not. Okay, so we're going to talk about hypercalcemia. So your symptoms, so classically you have, I'm sure some of you have heard about the common symptoms, so bones, stones, moans, and groans. So bones, so bony pain and fractures. So these are usually in diseases where you have bone being reabsorbed. So diseases like hyperparathyroidism, where you're having bone resorption going on, you can get bone pain and fractures. So stones is used to describe renal disease. So you're more prone to get renal calculi forming, nephrocalcinosis, CKD, and polyuria and polydipsia. Moans, so can get psychiatric manifestations, so confusion, depression, psychosis, tiredness and weakness. Groans, so abdominal symptoms, so abdominal pain, constipation, vomiting, can also cause ulceration in the stomach and pancreatitis. Okay, and signs of higher hypercalcemia, so you can get arrhythmias, various arrhythmias can be caused by it, hypertension, very dehydrated because of polyuria, polydipsia, and tenderness, bony tenderness over the sites where bone is being resorbed. So when you have a patient with hypercalcemia, you need to think about, is the PTH suppressed? If your answer is no, as was the case we discussed, then this is an inappropriate response to hypercalcemia, even if it is normal or raised, so inappropriately normal, as in this case. So most commonly, it is going to be primary hyperparathyroidism, so PTH secretion from the parathyroid that is inappropriate. More rarely, it is caused by familial hypocalciuric hypercalcemia. All this is a mutation in the PTH sensing gene, which means there's a higher threshold for PTH, there's a higher threshold of PTH at which the cells respond. So there's a higher threshold of calcium for which PTH is acting. Okay, and then if PTH is suppressed, so this is an appropriate response to high calcium, then you know that it's going to be a different cause. So most commonly in malignancy, so whether this is a bony, whether this is a solid tumor or hematological tumor, which is eroding into bone, causing it to be reabsorbed or destroyed, or whether this is a myeloma. Other rarer causes are things like sarcoidosis, vitamin D excess, hyperthyroidism, and milk alkali syndrome. Milk alkali syndrome is very rare, something that you won't need to know about. So as I said, hypercalcemia of malignancy. So 3 mechanisms for which hypercalcemia can be caused by a tumor. So this can be either the tumor is releasing PTH-like factors which are actually acting on PTH cells. So most commonly a small cell lung tumor, which releases PTH-related peptide, which is analogous to PTH and acts exactly like it. Bony metastases, so tumors like breast cancer, which which metastasize to bone and cause destruction of the bone locally. And finally, in hematological malignancies like myeloma, they release cytokines which act on local osteoclasts and influence reabsorption of bone itself. So how do we investigate hypercalcemia? So we want to do our usual blood test, full blood count using these magnesium and calcium, because magnesium levels can actually indirectly influence calcium levels. Phosphate, because phosphate levels again are very much related to calcium levels. ALP and PTH, ALP being a reflection of the bone turnover rate. We want to consider serum urine electrophoresis. Again, if you're thinking about myeloma being in the question, then urine electrophoresis would help identify if there's any Bence-Jones protein, and serum electrophoresis will help us determine if there's any monoclonal antibodies. ECG, so again, looking for those arrhythmias. So in hypercalcemia, prone to short QTs. X-rays can be done, so osteitis fibrosis cystica, so these are local bone erosions caused by increased osteoblast activity from bone resorption with excessive PTH action. Chest X-ray can be done, again looking for if there's any sort of lung tumor, because for small cell lung cancer, and a bone scan, again showing any localized hotspots for reabsorption. So how do we manage acute hypercalcemia? So we want to give IV IV fluids to correct any fluid deficits. So we want to really rehydrate the patient. Sometimes we're giving usually a litre every 4 to 6 hours over a day. And but once they're fully rehydrated, we can start giving 40 milligrams every 12 hours of furosemide. to make sure they're not become fluid overloaded, monitoring their electrolytes and fluid balance. If they're still hypercalcemic despite fluid resuscitation over a day, then we can consider giving bisphosphonates. So pamidronate's one that is commonly used, or zolendronate is another one. And we want to try and treat the underlying cause. So primary hyperparathyroidism, so as the case we were discussing before, is the most common cause of hypercalcemia, and this can be caused by either carcinoma, an adenoma, or benign hyperplasia of the parathyroid gland. Hyperplasia can be also associated with MEN1, which I'll talk about later on at the end of the talk, and it's much more common in women. So you have raised serum calcium, you have inappropriately raised or normal PTH, you have a low serum phosphate because PTH promotes renal excretion of phosphate and renal retention of calcium. You have an increased, because of this raised serum calcium, you have increased calcium being filtered in the kidneys, and this exceeds the renal threshold for calcium reabsorption. So you do actually get an increased urine calcium, 24-hour calcium. And you have a raised ALP because you have increased levels of bone turnover. You want to look for any signs of bone disease or stones, renal stones, and they may have signs of hypercalcemia, as we talked about before. So managing hypercalcemia that is due to parathyroid disease. So initially, if it's mild hypercalcemia and mild disease, we can just manage it by ensuring they have more fluid intake, reviewing their calcium, reviewing them every 6 months for their calcium PTH levels. Avoid thiazide diuretics because they can cause hypercalcemia, and avoid high calcium vitamin D. And in the long term, we'll be looking for definitive management, which is surgical excision of the hypoplastic glands or the adenoma. So we want to do an ultrasound or an uptake scan before to localize the adenoma or the hypoplastic glands. And during the operation, there will be intraoperative PTH sampling to confirm that the correct glands have been removed. So there are some complications of the surgery. Most commonly, like with thyroid surgery, recurrent laryngeal nerve injury. Because you're doing surgery near the thyroid gland and affecting parathyroid, you can end up making them hypoparathyroid and hypothyroid afterwards. There's a number of indications why surgery may be needed, but most commonly if they're quite symptomatic, if they're usually younger patients and more suitable for surgery, if their calcium is very high, or if they have significant bone or renal disease. If they have recurrence after surgery, then we can use cinacalcet, which is a calcium mimetic. So this is aiming to increase the sensitivity of your parathyroid to the residual calcium in the body. Just finally, here are the PTH independent causes of hypercalcemia that I talked about earlier. So sarcoidosis, because you have increased 1-alpha hydroxylation of your vitamin D. So you have more active vitamin D in the body, more calcium reabsorption in the gut. Thyrotoxicosis, because you get more bone reabsorption due to hypothyroidism. Hypoadrenalism, because you have increased renal reuptake in low cortisol states. Thiazide diuretics, again, because you get increased calcium reuptake from thiazide diuretic use. And again, excessive vitamin D, again, because you have increased gut reabsorption of calcium. So now, SPA, for your woman with CKD, recent blood tests show low calcium, raised ALP, and raised PTH. She has some bony tenderness and proximal weakness. ECG shows no abnormalities. What's the most appropriate management? Okay, 10 more seconds. Okay, so most of you said the answer is A, cholecalciferol, and so that is not the correct answer in this case, and I'll explain why. So this patient does have vitamin D deficiency, and they have osteomalacia because they have low serum calcium, raised ALP and raised PTH. They have secondary hyperparathyroidism. They have signs of low alpha osteomalacia, so bony tenderness and proximal weakness. However, they also have chronic kidney disease, which is the underlying cause for osteomalacia. And that means they have reduced activity of the 1-alpha hydroxylase enzyme in the kidney, which is needed to activate vitamin D. That means you need to give them pre-activated vitamin D, which is alpha calcidol. That's why that's the correct answer. So remember that cholecalciferol is vitamin D, but it's not fully activated. It needs to be activated by the liver and by the kidney beforehand. Ergocalciferol is another form of vitamin D which can be given, but again, it's not fully activated. It needs to be activated by the kidney. Cinacalcet, as I said before, is a calcium mimetic, which is used in refractory primary hyperparathyroidism. And levothyroxine is not correct. This patient isn't hyperparathyroid, hypoparathyroid, sorry. Okay, so hypocalcemia. Main causes can be classified into non-PTH driven disease and PTH driven disease because of hyperparathyroidism. The non-PTH driven, most common cause is vitamin D deficiency. This can be lack of vitamin D in the diet, lack from bowel absorption, lack of sunlight, or lack of activation of vitamin D, such as in chronic kidney disease, so poor 1-alpha hydroxylation. Can be due to PTH resistance, so your PTH not acting, so pseudo hyperparathyroidism. So they get hypocalcemia. Acute pancreatitis can cause hypocalcemic states, and also alkalosis as well is associated with hypocalcemia. And other side, you have low PTH rather than PTH resistance. So this can be iatrogenic, so surgical. So as I said, if they've had thyroid or parathyroid surgery, they may not have any residual PTH production. Autoimmune disease of the parathyroid is another cause. Congenital absence of parathyroid, such as in the George's syndrome, or magnesium deficiency. That's because magnesium is important in regulating PTH secretion. Okay, I think someone's asking. So someone's asked for the feedback link on the chat. So I don't know if on the BIMA committee you can just post that on the, for the chat for people who need to leave a bit earlier. So someone's asked about, can you use calcitriol for the previous question? Yes, you can. So calcitriol, like alpha calcidol, is fully activated vitamin D, so it can be used in treating patients with CKD who are vitamin D deficient. The only difference is alpha calcidol is 1-alpha activation only. Calcitriol has 125 hydroxylation, so it's fully activated like the body would. Okay, so presentation of hypocalcemia. So we have, so it usually has neuromuscular presentations most commonly, so carpopedal spasms in the hands and the feet, twitching of muscles, perioral paresthesia, fatigue and depression, and often dry skin with coarse hair. The signs, there's a number of eponymous signs associated with hypocalcemia. So Buser's sign, so when you inflate a blood pressure cuff on the upper arm, it can cause spasms in the hand. Chov-Stek sign is when you tap on the face just near the facial nerve. You can get twitching of the face. You can also get hyperreflexia and tetany, and there's a number of other features that are caused by neurological presentations like bradycardia, arrhythmias, and low BP. And hypocalcemia can be associated with cataracts chronically. So how to investigate this? Similar investigations to hypercalcemia, so your electrolytes, calcium, phosphate, magnesium. You want to measure albumin because albumin levels influence your serum calcium. Remember that a lot of calcium in the blood is bound to albumin, so that can affect your levels that you measure. ALP and PTH are important, as well as your vitamin D. ECG, like hypercalcemia, has a shortened QT, hypocalcemia has a prolonged QT, and it can be associated with other arrhythmias as well. How do you manage hypercalcemia? So acutely, if they're severely if they're symptomatic with hypercalcemia, you need to correct it with 10 ml, 10% calcium gluconate or calcium chloride over 30 minutes IV, and you need to correct any magnesium deficiencies that they have. If they have a mild symptoms, or if they're asymptomatic, you'd want to give them calcium and vitamin D supplements. So things like cholecalciferol and calcium. So things like calcium D3 are some common supplements that are often used. So management of primary hypoparathyroidism, very simply, you just need to replace, you don't replace PTH, you just need to replace their calcium and their vitamin D levels. Like with hypocalcemia in general. And we'll just touch on osteomalacia as a common cause of hypocalcemia. Because they're hypocalcemic, this means there's reduced negative feedback to the parathyroid gland. So this causes increased secretion of PTH, so secondary hyperparathyroidism. Okay, so they do have some of the features of parathyroidism where they do get bony absorption as the body tries to increase levels of calcium available. So that's why they get this bony pain and are prone to fractures. So they have causes of vitamin D deficiency most commonly. Chronic kidney disease is another cause. Anticonvulsants, because they can cause hepatic breakdown of vitamin D because they are enzyme inducers in the liver. Lack of sunlight because of lack of vitamin D activation. Liver disease, the same reason CKD, they don't have their 25-hydroxylation of vitamin D to activate it, and rarely vitamin D resistance. So causes of osteomalacia are features of osteomalacia, the bone pain, tenderness, for the reasons I said earlier, and fractures. They get this proximal myopathy because vitamin D does have an impact on your muscle strength. And again, because of this lack of calcium in the body. Remember that calcium is very important in muscle contraction. If you look on their serum plasma, they have low calcium and low phosphate because vitamin D is responsible for calcium and phosphate absorption from the gut. They have raised ALP and PTH because they have increased PTH secondary to the low vitamin D, and raised ALP because they've got this increased bone turnover to free up calcium stores in the bone. And if you measure their vitamin D levels in the blood, they would be low. Some people do a bone biopsy. This would show increased incomplete mineralization, and X-rays are usually done in these patients. They have low loss of cortical bone and usually reduced bone density, and they will often have what are known as Lucis zones, so pseudo fractures where reabsorption has taken place on the X-ray, usually in the femoral and humeral necks. Let's just look at some questions. So I've been told that magnesium has to be replaced before replacing phosphate in patient with hypophosphatemia. Could you explain why this is so? So usually, so from my knowledge, you usually can replace them together, magnesium phosphate replacement. So the reason why magnesium is important is because, as you said, magnesium does have an impact on PTH release and PTH sensitivity. So it can actually influence your calcium and phosphate levels. So you need to make sure that magnesium levels are adequate in patients with low calcium and low phosphate, because otherwise replacing them is not going to have much of an impact. And why isn't the activated form always used first line instead of cholecalciferol? Answer is because activated vitamin D is very expensive, so you only use it when you really need to. And could you compare the blood results of osteoporosis versus osteomalacia? Yes. So in osteoporosis, easiest way to remember everything is that in osteoporosis, all the blood parameters, calcium, phosphate, PTH, ALP, vitamin D are all normal. So remember that osteoporosis is when you lose this reduction in bone density, but not bone mineralization. So they're a bit different. So in osteomalacia, you're losing the amount of calcium and phosphate crystals in your bone, which are responsible for the mineral content in the bone. In osteoporosis, you're actually losing the density as well. So not just the bone minerals, but also the actual bony structures, the bony support structures, as well as the mineralization that is present. And I says, yeah, I think the slides and the recordings will be sent out as well for this. Okay, so just moving on. So managing osteomalacia. So correct what the underlying cause is, and you want to give them calcium and vitamin D supplements, as I said before. So if they are malabsorbing, or if they've got hepatic disease, I think vitamin D2, so urgocalciferol, is shown to be a bit more effective. So this can be given, or you can give calcitriol parenterally, which is the fully activated vitamin D, so 125 hydroxylated vitamin D. And if they have renal disease, or if they've got vitamin D resistance, then we usually give, as we said, for reason for alpha calcidol, because it's already been 1-alpha hydroxylated, which the kidneys would usually do, or we can again give calcitriol, because again, it is fully activated. So finally, multiple endocrine neoplasia, just something to touch on briefly, because it's something that does come up, not in terms of management, just being able to recognize it. So multiple endocrine neoplasia 1 is caused by a mutation in the tumor suppressor gene, which encodes menin. So these are usually sporadic mutations which occur in the 3rd to 5th decade of life, and usually presents with the 3 Ps as easier to remember. So you have parathyroid tumors, pancreatic tumors, and pituitary tumors. Parathyroid tumors, so you'll have your hypocalcemia from the adenoma. Pancreatic tumors, you'll have neuroendocrine tumors. Again, a very niche area, which I don't expect many of you that will need to know about, but they can present more commonly with gastrinomas. So they will have, so usually gastrinomas will be, you have recurrent or extremely severe peptic ulcer disease, which is resistant to treatment. Some of you may know this as Zollinger-Ellison syndrome, and insulinomas. So they have recurrent hypocalcemic episodes. Rarely you can have excessive stomatostatin secretion, lipomas, or glucogonomas. Again, won't touch into those because they are very niche. And pituitary tumors, usually the most common manifestations are prolactinomas or DH secreting tumors. They develop acromegaly. Okay. So I think someone, sorry, there's some questions. So why is osteoporosis not present with hypercalcemia? So when you think about osteoporosis, isn't actually the bone isn't actually being resorbed in osteoporosis. The osteoporosis doesn't necessarily have to have any resorptive activity going on. Osteoporosis is just when is by definition when your bone mass is, when you do a bone density scan, is less than 2.5 using on the Z scale. It doesn't have and there's a number of reasons why that happens. Most commonly it is actually just age related. As you get older, your bone density just reduces, but this isn't because your bone mineral was being resorbed. I mean, osteomalacia can be a contributing factor to osteoporosis, but they're not the same diagnosis. That's why when you're looking at your blood panel and you're looking at your calcium levels and your ALP levels and your PTH levels, you're looking for whether there is a reason why this patient's getting fractures. If they have low calcium, raised PTH, raised ALP, the reason that they're getting fractures is going to be because their bone mineral is being resorbed because they have lack of vitamin D, or they have another reason for osteomalacia. If their bone profile is all normal, and you do a bone density scan and their actual bone mass is reducing, because with age their bone mass is reducing, this is a structural problem rather than a mineral problem. So their biochemistry is usually normal. And just to add that, in a lot of cases, if you look at the actual bone in these osteoporotic patients and look at the actual mineral content, for the proportion of bone mass they have left, the mineral content is actually normal. So osteopenia and osteomalacia again are different. So again, osteopenia is going on to osteoporosis. So osteopenia is again when you're reducing your bone mass altogether, not just the mineral component of the bone. So I think the easiest way to think about it is when you think of your bone components, you have your mineral component and you have your structural component. In osteoporosis, osteopenia, they're both reducing in equal proportions. In osteomalacia, you're getting a reduction mainly just your mineral component. Okay, and I think this is the last slide. So mutations in the RET proto-oncogene are responsible for multiple endocrine neoplasia too. So this has a slightly different pattern of tumors that arise. So you get thyroid tumors in MEN2A. So these are usually medullary thyroid carcinoma. So the tumor marker for this is actually your calcitonin. You have adrenal tumors, so usually PHEOs, and you get parathyroid hyperplasia, which is usually the less common manifestation. More rarely you get MEN2B, which is similar to MEN2A, except you don't have the parathyroid disease, and you often have a more like a marfanoid appearance to the patient, and they have these neuromas which developed on their mucosal surfaces. So it's just about being able to recognize the pattern of the tumors in MEN1, MEN2A, and MEN2B are important. Okay, so that's the end of the talk.